South Library, Durham South Library on Alston 54. From 1 to 3, we'll be presenting our findings, and the Durham group will reach a consensus on a position regarding merger, recommendations regarding merger for Durham City and County. This issue was last visited in 1999-2000, at which point the proposal for merger was rejected, but things have changed and we're looking at it again. In addition, as sort of a follow-up on April 17th, Wednesday, April 17th, we're going to have a lunch and learn session on local government. And we'll have a representative from the Durham County Manager's Office to assist us with discussing some issues relating to city and county government, just to sort of a refresher for all of us on how things operate at the local level. And that will be at the Hibachi Grill, and I don't remember the name of that shopping center. Oak Creek on 15501. Yeah. We'll start at 11:30 with a buffet lunch, and the discussion will start at about 12 o'clock. And everybody's invited to that.
Thank you. So that's something we've been working on all year. In addition, tonight, before we get started, panelists, I hope you don't mind us doing a few little things related to the league. It is Women's History Month, and it seemed to me that it would be appropriate for us to think a little bit about our own history. And so we have with us one of our members, Bill Quitchard, who was on the Appeals Court of North Carolina and the North Carolina Supreme Court, and most recently Dean of the Campbell Law School, who remembers something that the league helped do a long time ago. So, okay, Bill.
Very quickly, a couple of things before I talk about that briefly. I was very interested to hear that Jane Shaw McClay had left funds for this kind of program. Her daughter Laura was my classmate all through junior high and high school, so I knew Jane almost all my life. And I certainly can imagine her doing something like this. And then the old issue of city-county merger in Durham. I was in the House and running for the Senate, I guess, in 1974 when Durham defeated a proposal like that 3-1. Senator Royal and I endorsed it, and I got quite a few nasty calls about it. But that's not what I'm here to talk about. What Brenda asked me to talk to you briefly about is North Carolina's ratification of the Women's Suffrage Amendment. You may not know the history. North Carolina had the chance in 1920 to be the state that put the 19th Amendment over the top. When it came to a vote in North Carolina, it had passed in one less than the requisite number of states, 36, I think it was at that time. And North Carolina had the chance to put it over the top. It passed the House, went to the Senate, and the Senate, which has 50 members, was known to be divided 25-25. Max Gardner, who was later the governor, he was the governor during the early years of the Depression, did a lot of things to consolidate things, make things that had been under the counties, under the state, very active and successful governor. But he was the lieutenant governor at the time. Walter Clark was Chief Justice of the State Supreme Court and was the leader of the women's suffrage forces in the state. And indeed was involved actually. He had written some legal commentary that was used to get the amendment ratified in states like Indiana. Lieutenant Governor Gardner had assured Chief Justice Clark that if the Senate cast a tie vote, he would break the tie in favor of the amendment. So it was thought going in that it would be a 25-25 tie. The Lieutenant Governor would break the tie in favor of the amendment, and North Carolina would be the state that put it over the top. Shortly before the vote was taken, one of the proponents went to the bathroom. And one of the opponents locked him in. And did not let him out until the vote was taken. And the amendment failed in the North Carolina Senate by vote. You may think that's not a true story. The man who locked the proponent in has a son who is still living and is a good friend of mine, and he says for the rest of his life his father bragged about that.
Oh.
But that's how close North Carolina came to be the state to put the amendment over the top. In fact, it was Tennessee, which was the next state to vote. And unfortunately, we had delegations from our legislature go out to Tennessee to lobby against it. Well, some 51 years go by. I am all of 30 years old, a freshman member of the 1971 General Assembly. And Ruth Mary Meyer, whom some of you may know from Durham, Ruth Mary is still living, was the lobbyist for the league, the state league of women voters. And Ruth Mary, and I suppose the league, decided that even 51 years later, North Carolina really ought to ratify the 19th Amendment. So she came seeking sponsors for it. She got Skipper Bowles to introduce it in the Senate and asked me to introduce it in the House. Well, I was a freshman. Skipper was in his third term, so the understanding we had was that Skipper would run his bill in the Senate, and I would then handle it when it got to the House. Politics got involved. Skipper was running for governor. And so was Pat Taylor, who was the lieutenant governor. And at that time, the lieutenant governor appointed the Senate committees, and Pat didn't want Skipper getting credit for something like this, so he told the chair of the committee to which he sent the bill to keep it in committee, not let it get out. So the long and the short of that is that it was my bill that got the 19th Amendment ratified in North Carolina. Once it was clear Pat wasn't going to let Skipper's go through the Senate, we ran my bill in the House, and then it went and passed the Senate. I'm pretty sure I've got these numbers right. I meant to check it today, but I'm almost certain this is right. It was 96-0 in the House and 44-0 in the Senate. And the men were stumbling all over themselves, talking about how important the women had been. Certainly won't vote for this. So that's my footnote in Women's History Month, and it was really your bill. I was just your legislative agent. Thank you.
Janet will introduce our speakers, and we'll move on. I would be happy to. Hello, everyone. Thank you so much for coming. I'm Janet Boyd, and I represent, of course, the League of Women Voters, and I'm delighted to have this panel with us today. Quick question. How many of you have attended prior sessions that we've had? So a lot of you. So this is the fourth and final session in our healthcare series. And as you know, we're focusing on the implementation of the Affordable Care Act here in North Carolina. And just to refresh your memory a tiny bit, we've had three prior speakers. Our first two were Dr. Pam Silverman and Dr. John Oberlander, who really provided us with a really good and very detailed and specific overview of the law itself and what it meant at the national level, what it means at the state level, and really provided a lot of detail about how that will all work. And then just a couple weeks ago, we had Wayne Goodwin, who is the insurance commissioner, come and talk about the impact on the regulator, the regulatory body that's supposed to help make this happen within this state. We know that there are some changes in decisions in terms of what the legislature has done, but his agency is really the one tasked with making the Affordable Care Act happen here in North Carolina. So he gave us some information about that, and his real focus is on the exchanges now, because as we know, the Medicaid expansion is not going to be happening in this state. So the focus will really be on the exchanges, and I think there's still a fair amount up in the air, and we're all going to sort of work our way through this. But he did provide some update on that, kind of how that whole thing worked. So our goal today is to bring together all of that information to sort of ground level here in Chapel Hill and Orange County. And that's why we have representatives here from a variety of different kind of delivery systems within our healthcare industry here locally. So we have hospitals represented, medical clinics represented, insurance company represented, as well as an insurance consultant who can talk about the impact of the Affordable Care Act on the employer population. Because we often are thinking very much about the public programs, Medicaid and Medicare here, but an awful lot of the premiums in our country are still paid for by employers, and they're impacted by this act an awful lot, and they're impacted by the exchanges as well. So our effort today is really kind of to bring together all of the information we've had up to this point, and to have a real kind of solid discussion about what's going on here locally, what will the impact be to local providers in a variety of different positions in the healthcare industry, and what would that mean to all of us as folks who live here. So the way this is going to work is I will do a very brief introduction of these folks, and then they will have up to 5 minutes to talk about their role, their organization, and really give you a little bit of background and information on what their organization is all about. Kind of who they serve, what their focus is, what their kind of strategies are in terms of the healthcare delivery system. So they will each have 5 minutes to do that. And then I have 3 or 4 questions or so to ask them that they can respond to. And then we're turning it over to you guys. So we want the majority of time to be spent answering questions that you folks have. So jot down your questions, think them up, and be prepared to ask them, because this is really the opportunity to do that. Okay, so we're looking forward to kind of a lively discussion. Okay, so Karen McCall, she will kick things off. Karen is the VP of Public Affairs and Marketing at the UNC School of Medicine, and she's representing kind of the UNC Healthcare portion of the business at UNC. Next to her is Dr. Abigail DeVries, and she is the Medical Director for Piedmont Health, which is a not-for-profit series of clinics that are offering largely primary care services throughout Orange County and other counties. Okay, so pretty broad range of services, but obviously different from a hospital. And then we have Skip Woody, who is a partner with Hill, Woody, and Chesson, and they are the insurance consultant. And again, they really represent employers in this equation. And don't forget that employers have a big role to play in how healthcare is financed in this country. So kind of an important piece of that puzzle. And then finally, Dr. Don Bradley, who is here from Blue Cross Blue Shield of North Carolina, and he is a senior VP and a chief medical officer. So I'm going to turn it over to them for introductions, then I'll just do a few questions, and then we'll turn it over to you guys.
I'm Karen McCall. I'm from UNC Healthcare. We are an 884-bed tertiary care, quaternary care hospital here in Chapel Hill. We just had our 60th anniversary. We were founded in 1952, and we have provided a wide range of healthcare, community care here in Chapel Hill for this entire time period. We have all of our physicians are members of our School of Medicine. So we have what's called a closed medical staff. We work very closely with community physicians and physicians throughout North Carolina. We get referrals from people throughout the Southeast and North Carolina, and patients from all 100 counties come to Chapel Hill. When I'm thinking of how the Affordable Care Act is going to affect UNC, is one of the things we're trying to plan for is, even though Medicaid expansion is not going to happen, we still feel a lot more people are going to get access to health care in North Carolina. And we have a hospital that's full a lot already, and we have clinics that are full, and we're trying to figure out how to develop the capacity to be able to serve new populations. So we've been working on this for quite some time. We're looking at new payment models. We're working very closely with Blue Cross right now in an experiment at Carolina Advanced Health, trying to figure out how to deliver primary care in the most efficient way. Some of y'all may have heard this past week that U.S. News and World Report said that UNC was #1 in primary care training in the whole country. So this primary care is something that has always been very important. Our Department of Family Medicine is ranked 2 in the nation. So this is a model going forward that we're looking forward to, and we think we're somewhat prepared to be able to deliver care in the best, most affordable way possible.
Great, thank you. Dr. Reese?
So I represent Piedmont Health Services, which is a group of community health centers. There's 6, soon to be 7 sites, as well as a PACE site. And PACE is in-home care for elderly who are nursing home eligible, which provides services at the patient's home and in the center. It's complete care, medication, therapy, physician visits, as well as the social component. So that's something new that we started about 3 years ago. But historically, we've been community health centers, and we're designated as an FQHC, and that's a federally qualified community health center, which means we get federal funding to help us take care of uninsured patients, to offset the care. So 59% of our patients this last year were uninsured, but we do take all insurance payers as well, Medicare, Medicaid, private insurance. And we take care of a very poor population. 98% of our patients are below 200% of the federal poverty level. Like I mentioned before, we take care of patients in really in about 10 counties probably around here, but we have sites in Chatham, Alamance, Caswell, just North Orange County as well, and the PACE site is in Burlington as well. We have many services at our sites, not just medical. We have dental at 4 sites. We have pharmacy in-house in all of our sites. And patients benefit from pretty cost-effective medications through the pharmacy. Let's see what else. So as far as how the Affordable Care Act is going to affect us, I mean, we are also trying to figure out how we can increase capacity, but also planning on still having a fair number of uninsured patients to take care of. So we're trying to figure out how to expand, but also be efficient. So we have a very cost-effective model. We always have. It costs us about $500 a year to take care of a patient with, for example, diabetes. So very cost-effective, and also focused on quality. So we're Joint Commission certified, which is generally a hospital certification program, but it really focuses on patient safety and quality. And we are about to go through that survey again. It's every 3 years. And we're also working on becoming a patient-centered medical home, which is a new initiative also focused on quality and the patient being sort of at the center of the experience instead of the physicians and the staff of the site. So that's a little bit of that.
I'm Skip Woody. I'm a partner at Hillchesson & Woody, and I'd like to thank Janet for the invitation. I'm sorry I missed the first 3 meetings. Sally had a great list of speakers. Can I get on the mailing list?
You bet.
Hillchesson & Woody is it's a health and welfare benefits consulting firm, and we're somewhat of a boutique firm in that all we focus on is employer-sponsored health and welfare benefits. And I'm here representing 350 to 400 employers here in North Carolina who are providing benefits to their folks. One of the questions I saw is, percentage of your customers that have insurance. 100% of my customers have insurance. I help them figure out how to finance that and what they should offer their employees. And the Affordable Care Act, it's required my company to grow tremendously. In fact, UNC Hospitals bought my building in your expansion for space.
Yes.
Thank you.
You're welcome.
And yeah, so we needed that to accommodate all of the demand that the uncertainty of this new law was putting on employers. I have 4 attorneys that have done nothing but read day and night on the healthcare reform bill, trying to understand it and trying to figure out how employers can manage all of those responsibilities. It's kept me very busy. This is my 3rd presentation today, so I'm saving my voice, and I want to hand the microphone over to Dr. Brown. I'm glad to be here. Thank you.
Great. It is a pleasure to be here, and I appreciate it. I think one of the things that was interesting to me is I was listening to the history. Hello?
That's all, just hold it really close to your mouth.
My mother was actually very active in the League of Women Voters, and in fact ran for a state legislature back in the early 60s in Minnesota. so I can remember campaigning as a 9-year-old at the time. So I have a fond place of great cookies at these events. So my own background is I'm a family doctor by training and demeanor. I am also a recovering academician, having practiced. I actually started out practicing in South Boston, Virginia, which is about an hour and 15 minutes north of Durham. Moved to Duke, ran their clinical programs for the Department of Community and Family Medicine, and then moved to the dark side back in the late 80s. Have been at Blue Cross Blue Shield since. Chief Medical Officer essentially means that you do everything but wash the windows on our building in Chapel Hill. We have the care management operations, we have the pharmacy management operations, quality, network performance, healthcare evaluation research. We actually do the appeals. So it's really anything that Blue Cross does related clinically falls in my shop. Blue Cross Blue Shield North Carolina itself covers about 3.8 million people in the state of North Carolina. That's about a third of the population. It's about 50% of those with commercial insurance. We have about 4,000 employees. We're based in Chapel Hill, the building that most of you know. And we were founded in 1933, so we've been around for a while. I think just in terms of how we see what we do is fundamentally we're here to make the healthcare system better in North Carolina. I think we focus on 3 areas. One, as Dr. Rees mentioned, is to focus on the patient, to keep the patient in the center. We would call that a customer. You might call it a citizen, but in the end, it's really talking about the patient should be at the center of this. The second is we need to be more collaborative and innovative in the approach. I think Einstein's definition of insanity was doing the same thing over and over again and expecting a different result. So I think we're going to have to step out of the way we've done things historically and move on to new territory. And then finally, it's really working to have the healthcare system be more efficient and effective. So those 3 things are really what we're doing. I look forward to having a discussion on the impact of ACA, and we'll turn it back to Jen.
Thank you very much. I want to make a quick comment too. We are so pleased that we have Carol Edmonds here, who is doing videotaping of this session, and she videotaped the last session as well. So if you're interested in seeing Commissioner Goodwin or this panel discussion or tell other people about it, it will be posted at the LEAP website, just so you know. Thank you very much for the introductions. Appreciate that. So again, I'm just going to ask a couple questions, and then we'll turn it over to you guys for questions. Some of you, I think, answered this a little bit, but I'm going to frame it a little differently. Since the Medicaid expansion will not happen, what will be the impact on your organization?
I'll start from UNC's aspect. We're really concerned that with the way that this was all set up was that Medicaid was going to expand. Healthcare providers were no longer going to have as many uninsured patients to treat. At UNC, we probably provide about $300 million uncompensated care a year to take care of the uninsured and people that don't have full insurance, bad debt, other things. Medicaid was going to expand. More people were going to be able to have insurance, and we knew that the prices were going to go down. So the way it's going to happen now is we're not going to have Medicaid expansion. We'll continue to have a large number of people that don't have insurance, and prices are going to go down. So nobody knows exactly.
Prices are going to go down?
Right.
She means costs or prices?
No, the price that we think that Medicaid and Medicare reimbursement
Yeah.
It's going to go down.
Yeah. Yeah.
And we have about 60–70% of our, the people that we serve are in Medicaid and Medicare already. And then we have the uninsured in addition to that. So we're very, very concerned about how exactly the equation is going to work. How do we continue to be able to provide care for the uninsured if they are no longer able to, if they're not able to have expansion, and the trade-off isn't there anymore the way it was originally planned. So that's what we're concerned.
I think our concerns are similar. I mean, one is for the patients. I mean, so 59% of our patients are uninsured. Not all of them are going to qualify for Medicaid, but looking at the Massachusetts experience, probably about 30 to 40% would get Medicaid. Yeah. And so now those people will continue to be uninsured. Fortunately, they'll be able to come and continue to see us, but there's many other uninsured people who can't get in to see us because we don't have enough access. So I think it's, and it's not going to help us be able to expand. I mean, one thing we're hoping is that with increased Medicaid revenue, we'd be able to open another site or two and be able to serve all these people who now have insurance. I think we still anticipate that some of our patients without insurance will get insurance through the exchange, but then again, that's people with a higher income level than what we're generally seeing. So the other thing that's concerning for us is that as part of the deal that was made, and I'm going to get this quite right, in December, with the federal government, some of the money that was put into a trust for health center funding was kind of taken out and used for our daily operations, and that's going to kind of run out sooner than it was supposed to. And so we're also in danger of having our federal funding cut in the next 2 to 3 years. And if Medicaid had gone through, that would probably be fine. But now we're going to have this perfect storm in North Carolina of decreased federal funding, continued uninsured, and not having this kind of Medicaid fund. So it's very concerning for us. I mean, we'll still be here, but we won't be able to see as many patients as we're going to be able to.
I would just mention one other thing. I mean, UNC is in, we're concerned about this, but the hospitals in rural North Carolina is really where you're going to see the real hurt. Folks are very concerned whether they're going to be able to stay open. So UNC is not, that's not going to be a problem. We're going to figure it out. But in small hospitals that are not affiliated with larger systems and things like this, there's very, very big concern that they'll be able to keep the doors open.
I guess I can chime in on the employer perspective on this. From an employer perspective, if you have a population of employees with a very, very low wage that are working just barely enough to be full-time, the expansion would have covered some of those working people, and that just simply means that the responsibility of healthcare would have been put on the state rather than that employer. So probably not a tremendous impact to most employers, but it will have some impact if your employee population is at that low wage. I also understand that if we can't get everybody covered and get everybody in the system, we can't start to try to change things. In the long run, that's what we want as employers, is to get everybody covered so that we can stop some of that cost shift that takes place from the uninsured to other forms of revenue, whether it's private insurance or other means.
So I would go back just a bit and make sure that folks understand what Medicaid covers and what it doesn't. It really covers pregnant women and children and those that are blind, aged, and disabled. So being poor does not make you Medicaid eligible. So we've got a lot of folks out there who are not, that don't have coverage, that will continue to not have coverage. That said, the safety net will still be there, and as folks have mentioned, docs and hospitals will take care of patients who show up, particularly in your emergency rooms, as they have today. The problem with that is that it's expensive. It's an expensive way of doing it. So when I talk to Janet's, when I talk to UNC Hospital, they're going to tell me all about the unreimbursed care and their low reimbursement, and that they still need to pay their doctors, nurses, and other folks, and thus Blue Cross Blue Shield will have to cough up considerably more. So from an employer and from individuals buy insurance, the cost will remain high. Now, let's also be clear, you know, the legislature and the governor have made a decision in North Carolina, and we're going to have to deal with that decision. I think it is the law that made the decision. Yeah, that's really our role.
So I think we've seen the cost shifting right along this panel right here in terms of, you know, you squeeze it at the end of Medicaid and government programs and the safety net programs, and we're going to pay it as people who get employer-sponsored coverage. So that was really apparent. So thank you for being so explicit.
So we sat in the right spots.
I think you did. Absolutely.
Just one other thing. I think, of course. So right now, Medicaid extension is not going forward. I'm hopeful. Maybe there's a little bit of hope that, I mean, you can always overturn a law or pass another law. So I think that there's a lot of advocacy that needs to go on in the next year on the part of the state level to try to change the course.
Okay. So a similar question, sort of follow-on question. I assume that the provider organizations will participate in the exchanges, the North Carolina exchanges. So do you anticipate any sort of changes in terms of how you deliver care by through the exchanges? Will anything change for you as far as patients you see or anything other than sort of structural changes?
Well, we anticipate that there, with the ACA and the way that healthcare is changing, regardless of the law, there's going to be more of a push towards primary care. And so we think that people that are signing up through the exchanges, as people in groups like this become more educated, I think people are realizing that specialty care that's in isolation is not even providing the very best care. You need to coordinate care the best you can. And so we're anticipating that as people are more educated, as the systems are changing, we're going to have to provide more coordinated primary care for the population as a whole. And so those are the kinds of things, as I mentioned, with Carolina Advanced Health right now here in town, we've got basically a major experiment going on of providing primary care for people with chronic conditions, and with the explicit aim of keeping people out of the hospital and providing the care at a more local, home-based environment so that they can not be going to the emergency room, not being readmitted, not being in this constant revolving door in and out of the hospital. So those are the things that we're working towards to really set up so that we can be in a position to take better care at lower costs.
One of the questions was, will we participate in the exchange? Absolutely. We will also participate off the exchange. There will be employer group insurance, we hope. There are some questions about whether employers will look at the cost of providing insurance on the, as it is today, and whether they will dump those folks into the exchange market. One of the keys that will be different from my perspective with regard to folks who sign up via the exchange is that we will move from an employer-based insurance to an individual consumer-based insurance. And that has some benefits, but it also takes away the employer's leverage working in synergies with the health plan to help change patient behaviors. So here we are trying to get folks to eat better, not smoke, be more active. Employers have a lot to do with whether that happens in their workplace in conjunction with the benefits it provides the health insurance. So we'll need to help figure out and work with providers. Collaboration is critical on how we're going to help folks keep, improve their lifestyle so that we can keep the overall cost of health care down. It's going to be an interesting process regardless, but I think that's one of the key issues.
Well, for us, for employers, Blue Cross will be in the exchange. There are also a couple of other insurance carriers that have indicated they're going to participate, but not everybody. that's what I find interesting. There are a couple carriers out there that are going to make the decision not to play in the exchange, so to speak, and they'll be off the exchange only, and that creates interesting marketing opportunities. To us, the exchange is, the new name, by the way, is Marketplace. So we're trying to move away from exchange and we're moving towards Marketplace. That's the new term, because it's just another place to go to evaluate insurance options. And employers will be, first of all, small employers. In North Carolina, it's businesses with less than 50 employees will be able to take advantage of the small business health exchange to buy coverage there. And if you have a small business with less than 25 employees with average wages below, I believe, $50,000, you may qualify for a tax credit through the exchange. And then, of course, individuals will go to the exchange as well. And I believe there will be lots of new patients that will come in with insurances. I hope so. And there'll be some businesses that might start offering insurance because they might qualify for one of these tax credits. Although the tax credits that we had in 2010 really weren't enough to get businesses to buy it. One of the things interesting about the exchange, you were talking about it earlier, is that we don't know all the details on it, but what I've seen in terms of application process to actually get coverage that's subsidized through the exchange, it's a fairly complicated thing. And we anticipate that we'll continue to grow and to help individuals and small businesses figure out where the best places for them to actually get those benefits. Contrary to what a lot of people hear, that the pay or play, that's that rule that says employers need to either provide insurance or pay a penalty, and there's conversation about we're going to drop insurance. Well, there's no law that says that these employers have to offer insurance today. There's been no law that said employers have to provide insurance for the last 20 years, but they have. And I haven't talked to a single one of my customers that has said to me, Skip, I need to figure out how I'm going to tell my employees that we're dropping. Because the reasons they want to continue to provide over the next 10 years are the same reasons they have provided in the past. It's about getting quality people to stay long-term to fill the greater mission of whatever the organization is doing. So I don't think we're going to see the employer market dwindle much. Maybe they're very, very small, but I don't think any employers of any size will be dropping out.
The one thing that I think may impact that is when we look at what the cost of health insurance will be come 1/1/2014, it will be more expensive. There will be more people with access to health insurance. There's a lot of health insurance reforms as a part of ACA. So to cover more people, there'll be more benefits, but it will come at a cost. And I think there will be some calculus being done by people all over the world, both small and large groups. I hope they don't folks into the exchange. They can do that in a number of ways, whether it's by providing a dollar amount or just saying, I'm not out of the business. But I think the cost of what's coming with the Affordable Care Act, we're just beginning to really understand, and we do need to understand it to be substantial.
Excuse me, he drops off. We can't hear if he moves his head or something. We can't hear what you are saying.
Okay, so it's time to turn it over to you guys. Who's got a question? Okay, Pat, now borrow the mic, and we can, yes, you guys use the mic too.
My question springs off the recent Time magazine feature on hospital costs, and specifically talking about what was termed charge master. And I am wondering why it is that hospitals, as very large institutions, buyers of so many pharmaceuticals and products and so forth, and also insurers who are very much interested in the cost, why have we gotten to the point where these large buyers are not able to buy many of these products at reduced prices and pass them on to patients? You're looking puzzled.
Yeah.
Pass the savings on to the patients.
There are low-cost providers in North Carolina, and there's a wide range of reimbursement charges for hospital services in North Carolina. And among the lower cost providers among academic medical centers, UNC is one of those. We've been trying for a long time to have the best financial assistance policy that we can for all payers. We've had a policy in effect for years where what we charge people that are uninsured is automatically in line with what insurers pay. So charges are an artifact of requirements that we've had for years from Medicare and Medicaid in terms of reporting our costs. And so many times this hospital financing is built on requirements from the government and external payers that have required us to maintain historical charges, and also for the state of North Carolina, we've been reporting our costs for years as a state institution. So I don't know, I wish it was different. I wish it was easier for people to understand, but it's built on years and years, basically traditions of ever since Medicare came into being in the 60s. There were certain requirements that have come about, and we still, everybody in hospitals are following hospital financing guidelines that are based on those strictures. Does that answer your question at all?
No.
All right, I'm sorry.
Do you want to try again?
I don't know. I wish I could tell you that the charges. I wish that the charges didn't have to be presented the way they are, but a lot of this is based on external guidelines.
I think maybe I can try to rephrase, because I've dealt with charge masters.
Okay.
Did you read the article in Time?
Yes.
Okay. There was a fair amount of discussion on the apparent arbitrary nature of the charges that were included in the charge master of many, they were talking about not-for-profit hospital systems. And I think maybe your question is the need to adjust those charges because they don't reflect the quantity discounts that hospitals should be able to get because of the volume of services they provide?
No, the volume of items that they purchase
Okay.
and then charge patients for.
Many times, as it was very apparent in the Time magazine article, the charges are a historical artifact at this point. We're not receiving those charges from anybody. We're receiving reimbursement based on contracts with insurers, government paid, itemized billing, so we're not receiving any funding directly related to those charges at this point by the charge master. We're getting reimbursement from the insurers and from the government. That is, in the case of the government, they will be many times arbitrary also, dollar amounts for specific services. And we're not getting those dollar amounts, and we're not charging anybody those dollar amounts. The uninsured get automatic discounts from those charges that are reflective of what we're paying, what we're being reimbursed by other payers.
Excuse me, could you just talk about pharmaceuticals as an example of buying in quantity and getting economy of scale out of pharmaceuticals? You do purchase pharmaceuticals.
We do purchase pharmaceuticals, and it's a little bit different than what the drugstore is able to charge, because there are administration charges, and there's a 24/7 group of people that are providing individual administration of those drugs. Many times the drugs have to be mixed. There's a whole series depending on what kind of drug it is. But once again, what we're charging, we're not receiving as reimbursement. It's a charge, but it's not what we're receiving as reimbursement. Yes?
My question is, if you're not receiving anything close to what's being charged,
Right.
why are we seeing bills that have such huge value? Why don't we see something more realistic so the rest of us aren't so angry?
Yes, I wish people weren't angry also.
I mean, it's ridiculous. Why?
Because Medicare and Medicaid have required for years by law that we have charges and that they reimburse us. That is a starting point. Now, in our financials, we don't even post what the gross charge amount is. It doesn't even appear in hospital financials. We only post net revenue, which is the money that we get in reimbursement. So the billing and the charge items from the charge master are an artifact of requirements that we have to face from Medicare and Medicaid cost reimbursement. And it all starts from charges, which they say you have to maintain a charge master.
Dr. Bradley, I just wanted to
So
come in.
I'm going to, not that I'd like to rescue a hospital system, but we are trying to collaborate a bit here. You know,
We'll hold it up really close to you.
like that. So when we negotiate with any health system, UNC, anyone else, fundamentally what we're looking at is what's your total cost of care, and how you divvy that up is, there's always cost shifting. Why are we paying more for a bed day than Medicare is? It's because they've got a set of costs they've got to meet. And the same can be said for, there are parts of the hospital that are profitable, there are parts of the hospital that lose a ton of money. So we understand that, and rather than just trying to beat on folks, it's kind of like, let's look at, you look at what your costs are, your true costs, and then let's talk about what a price is. I think I would move to what I think some of the solutions are to that. One, Medicare already pays on a DRG basis, so a lot of this stuff is bundled in the sort anyways. But I think more, diagnosis-related groups. So if you're admitted to the hospital for a given diagnosis, and there's places to play around with what diagnosis and how many complications, so on and so forth, but fundamentally the hospital gets paid a single, a set amount for that bundle of care. Now, I think transparency is something that we could all use, and more of it. But maybe more important is that we need to be paying for the quality of outcomes rather than the quantity of services. And I think, and I would say in our discussions with UNC and many other health systems, they would agree that, let's be transparent, let's focus on the quality and the outcomes, and then make sure the price gets, done accordingly. One of the things when I go out and talk with hospitals is, they'll say, well, we need an increase of X percent, usually double digit. My response to that is, you may or may not, what I need you to focus on is what's your margin, not your total revenue. 30% of healthcare, according to the Institute for Healthcare Improvement, 30% of healthcare is wasted. We need to work on that 30%. And again, let's be clear, the hospitals are working on this as fast as they can. And part of our job is to work with them to find out where the wastes are and how we can reduce some of that inefficiency and ineffectiveness. So I read the Time magazine. I was glad just to have the insurance companies not being beat up for something for a change. But we do need to dig underneath the hood on this a little bit better. We need to expand the whole concept of bundled care, and that's something that we're doing with a number of providers at Blue Cross Blue Shield. If you need a knee replacement, we're working with some providers, not everyone, to say, you know, for the 30 days before you have a procedure and for the 60 days afterward, there'll be one fee. If there's a complication, that comes out of your pocket. So it behooves you to do a good job. That creates better patient experience, better outcomes, and at least are predictable and generally a lower cost.
So we go from the provider to the insurance company to you. So when there's a double-digit increase in your fees charged for the services that you receive from any healthcare provider, that goes to the insurance, and then that cost gets, you know, added to your premiums, and that increases your cost. Employers today are acting more like risk managers than normal purchasers of healthcare. They're looking to buy insurance products that drive employees to high quality, towards bundled payments, to cost-effective care. And this transparency isn't there yet, but there are strides being made in that direction. So I think this is neat. You can see it all happening right here. Out to you.
And I'll just throw in one of the hospital solutions is something like we have at our PACE program, where we actually, it is a capitated model. We get paid something slightly less than the Medicare rate for a patient being in a nursing home. And we're responsible for, if they go to the hospital, we pay UNC when our patients go to the hospital. We pay for a nursing home bed if they come out and can't go right back home. And so it encourages us to focus on quality and cost effectiveness. We use the 340B pricing program for medications that allows, it started to help health centers actually be able to afford medications for their patients, and we pass those savings on. We pass those savings on to Medicaid, because when a Medicaid patient gets medications at our pharmacy, we charge them what we charge an uninsured patient, which is much less than a retail pharmacy would. But the capitated model and paying for performance and paying for quality could really cut out some of these extra costs.
And if I could go ahead and drag everybody else in the room into the equation. Can you all hear me now? 87 cents on the dollar of healthcare premium is medical expense. The medical expense goes up in part because of technology, in part because of waste, but it has 75% of that 87% has to do with chronic conditions and lifestyle choices. So patients, consumers, have a large part to do with this. You know, the obesity epidemic is rampant. Diabetes is increasing, particularly in children. So everybody's got a piece in this. Some of it's hospitals. You can talk about charge masters, talk about insurance companies. You can talk about providers, but we all are in the same boat, and we all have a part to play in really making this work better.
I have a question for everybody. Karen, first of all, this is not. When you talk about uncompensated costs, is that the cost, the insurance cost, the Medicare cost, or what are you using for cost when you talk about uncompensated care?
I'm using a calculated cost of the labor, the supplies, all the different components and resources that we use to provide care.
So it's not the insurance cost?
No, it's not the insurance cost.
It's the cost of providing care.
It's cost of providing care, and we have that information.
And secondly, I was disappointed that UNC Healthcare said nothing about the expansion of Medicaid. Duke talked about it. A lot of other healthcare systems did, but UNC was silent.
Many members of the faculty were very, very vocal, and we were very, very vocal with members of the legislature.
But I didn't hear Roper being vocal.
Oh, he was definitely being vocal.
Okay.
Yes.
Now, for Piedmont Healthcare, I want to give you a kudu. When organization of companies that fought Medicare and Chamber of Commerce. At the time they were fighting Obama's Medicare plan, you guys were providing primary health care to small businesses and members of the Chamber of Commerce and Chapel Hill. At the same time, they were trying, the big boys were trying to wipe you out. Now, for the insurance guy, McDonald's gives you insurance, but it doesn't cover crap. Do you, are you part of that, providing those kind of policies? Or do you provide policies to your businesses that actually provide adequate coverage for the patient? I got one more.
First of all, I always like questions with a finger pointed at me. So thank you for doing that. Very in tune to what you're saying. You're referring to a limited benefit medical program, and those are no longer allowed. So at the end of this year, they all go away. Did I ever provide any of those? My clients are interested in keeping their employees, so they offer something that is more quality and provides more comprehensive coverage than the limited type plans that you're referring to. Those plans don't provide enough benefit, as you know, and therefore they don't meet the rules. We don't need them anymore.
And now for Blue Cross Blue Shield, I hate your commercial with the 20-year-old standing there with the tube, the angel and the devil, saying, I need to buy insurance. And then if you read the fine print, it tells you if you're 20 years old, your premium will be $100. Well, your premium is going to go up when you get into the exchanges, and you have to cover everybody. It is untruthful, in my view, to run those commercials. You need to say what it would cost if you were on the private market and you were 50 years old trying to buy insurance. You wouldn't want to advertise that because it would probably be $20,000 a year. So when the insurance exchanges occur, the premiums for the 20-year-old is going to have to go up to pay for the 50-year-old. So are you going to stop running those commercials?
They have.
No, I just swallowed.
So you know the definition of a great question is one I have an answer to. A good question is one that needs to be asked, but I'm not sure. So first of all, those commercials get the phone ringing. And there are a number of folks that, I mean, we run them because it actually draws business into Blue Cross Blue Shield. Now the other thing is we sell insurance online. You can get a cost estimate of what your insurance will be. So, you know, we want you to call in or go online, but then we're not trying to say, no. You know, it's only going to be $100. I can tell you that much. My son moved from turning 29 to 30, got into a different age group. His insurance went up fairly significantly. That's the way it goes. Now,
that's the way it shouldn't go.
Well, so that depends. If you're a young, healthy person, it really stinks.
But they're going to be old eventually.
Eventually, the issue is that part of what ACA does, besides increasing access, is it really does a number of insurance reforms. We're going to compress the highest rate to the lowest rate. And if you're a 20-year-old healthy white male, your rates are going to jump like crazy.
Right.
If you're a sick 60-year-old person with multiple chronic conditions and expenses, your rates may go down. And overall, the median cost of insurance will go up, in part because we're bringing some sick people into the market, their new taxes, their new benefits to be on there. But I always thought those commercials were not my favorite, but they do get the phones ringing and we do get people, and we need young, healthy people in the health insurance system to pay for the rest of it.
One down here, not
Okay, thank you. Wanted to add to what Dr. Reason said about the health exchanges. I'm Carl Dale, I'm Director of Pharmacy Services for Piedmont. We do have a lot of concerns about the health exchange. As she told you, right now we have 59% of our patients are uninsured and 98% are at or above 200% of federal poverty level. So we see the majority of our patients are extremely low income. So one of our concerns about the health exchanges are these people, when they get insurance, and we hope they do, are they going to have high deductibles? Does it put everybody back in the same boat? Now they can come to us, on a sliding fee. If you're low income and no insurance, you pay a sliding fee. So our basic sliding fee slides down to $25. So the majority of our people, uninsured patients, are paying that. We do have the advantage of having the pharmacy program, as you mentioned, and I can give you a happier story than what you talked about at the back about the extremely high prices. In 1992, the Clinton administration initiated a federal program called 340B, which brings low-cost pharmaceuticals to communities like ours to the point that our average drug cost for these uninsured patients is $10. So a diabetic patient that's normally paying $500 to $600 for the diabetes medications and supplies can get their supplies with us for less than $100 usually. So that's a very important thing that to look at when you're looking at a community health center. So the other positive thing of that, which Dr. Breeze mentioned too, also in terms of savings, when we bill North Carolina Medicaid for our Medicaid patients, we also bill at the lower rate. Consequently, our average bill per prescription to North Carolina Medicaid is $17 per prescription. The average in North Carolina is $77. So essentially, we're saving the state $60 on every prescription that we bill to Medicaid. So there's some positive things about using the federal programs to really keep costs down. That's one thing that Piedmont is really good at, is being a low-cost provider, because we have to do.
Thank you. Excuse me for walking right in front here.
Ladies and gentlemen, I have a question, but first I should tell you who I am. I used to work for Medicaid Blue Cross 40 years ago, and so I saw, working inside the company, just how corrupt Medicaid medical payments were. I'm not blaming Blue Cross, it was the system at that time. My gripe is this: along with hundreds of other women clerks who brought up the bills and made the payments to the patients in the hospitals, we became aware, we talk about things. For instance, patients would come into emergency with the most ridiculous medical conditions. It was common to have people come in with a hangnail. By the time they walked out, they had a $1,000 medical bill. Is that waste? Oh yeah. And just recently, when we built our house, our carpenter's son got pink eye. He went to emergency. $500 to take care of that, and a few little eye drops would cure the boy. This kind of thing goes on, and who gets stuck? The taxpayers. My complaint is this: can't there be some kind of effort between the mimic clinics that treat very economically pink eye and hangnails, and not have major medical institutions like Duke and UNC treating this kind of thing under Obamacare? Thank you.
So there's a couple pieces of that. I didn't even know that Blue Cross actually had anything to do with Medicaid. So maybe it should be
Michigan.
Oh, Michigan, thank you.
Keep the mic up.
Well, it wasn't me. So Community Care of North Carolina is one of the key players in Medicaid here. One of the deals they have with the emergency rooms is that patient shows up there, they get a hold of CCNC, and they are doing a great job of moving those folks out of the emergency room. So I think Community Care has got a good record of showing that when you do manage patients and provide alternative ways to get the care they need, that can be very cost effective. I also think we bring up the point really of we need to think through the models of care with which we deliver care. So minute clinics, fast meds, CVS has got, I guess it's minute clinics, online care, group visits, I mean, there are internet care. I mean, there are a number of things we need to think through. What pharmacists can deliver a lot of different services, particularly with chronic illnesses. We've got to get off of our parochial way of delivering care and really think through it. I think Piedmont's probably doing that a fair bit with nutritionists and social workers and so on, getting the services that need to be done. So I would agree with you, there are more efficient ways. We do need to keep people out of the emergency rooms, and that's precisely what we're working on.
We also at UNC offer UNC Healthcare, which is a nurse triage program that you can call 24 hours a day, 7 days a week, speak to a nurse, and determine what level of care you really need based on provider-based protocols. So we provide that service for Duke, for UNC, for Piedmont. So there are alternatives here in this community to call Helpline, speak to a nurse, and know what the level of care that you really might need so that you don't have to unnecessarily go to the emergency room.
One of the tenets of patients at a medical home is having access actually in the medical home. So a minute clinic is a good option. Even better if you could see a primary care doctor who could check your diabetes levels while they're treating the pink eye. So having, in our clinics, all have at least one evening hour. 3 of our sites have Saturday clinics. And then we use HealthLink, and HealthLink calls us if it's an issue. And then we would love to explore models with insurers to get paid to do the phone consultation instead of having to go to the ER, because that's absolutely more cost effective. CCNC, which Dr. Bradley mentioned, pays primary care providers a per member per month fee to manage their care. We work with their care managers if there's repeat flyers in the ER to help counsel the patient, make sure they know how to get to us, and they'll have the transportation and things like that, so they can get to us instead of to the ER.
And I don't know if everybody realizes that UNC has a very strong partnership with Piedmont. We have actually had multiple year contracts of providing hundreds of thousands of dollars to Piedmont so that a lot of patients can get there for their care and not be in the emergency room. So this is something that we're actively pursuing.
Let me just kind of add one other piece of transparency. For those of you who are on Blue Cross Blue Shield insurance, there's an app that you can find at Urgent Care Center. You can look at the cost of your prescription drugs. I think this transparency and finding other ways of delivering the care you need and getting it to people at the time that they need to make decisions is critical. We're doing that for Blue Cross Blue Shield. I think that's the kind of information we're going to need for more people going forward.
Question?
Am I?
Yes.
Is it on? I don't know. I don't speak with it.
Yeah, just hold it close.
So this is a great panel. Thank you so much. And 2 things that I gleaned right off the bat. Your question about hospital costs. I think everyone got the message that government intervention by the Medicare and Medicare costs are what dictate a lot of it. So it's not the hospital's way, it's the intervention of the government that has skewed the costs that you are paying. And then the doctor from Blue Cross, thank you so much for talking about how your premiums will go up. This is not about healthcare costs going down. I hope you all heard that. Your premiums will go up, contrary to a lot of plans by the president and the people behind this act. So my question is, as the wife of a trustee at a rural hospital, for 25 years in Person County, my husband and I have been actively involved in doctor recruitment. We have no doctors. We just lost a general surgeon. It's only a matter of time before the other surgeon leaves. He cannot be on call 24/7. He can't cover all the costs. I mean, all the, demands. We're not getting anywhere. We haven't had an OB in 20 years. So, my question is, no one speaks to, and I know this isn't your exact expertise, but no one is speaking to the loss of the doctors under this. I am terrified for our hospital and our community because with decreased reimbursement under Medicare, y'all have all heard of the doc fix, which is often talked about as a way to reduce Medicare costs, but actually is never passing in Congress because they know what that will do to the system. So we stay at the higher cost to us, of course, trying to keep the reimbursement low. So if it goes lower, the doctors will stop treating in the system. So what is the plan? Who knows anything about how we're going to keep a level of physicians in our communities when we have 30 million more people potentially covered under the Affordable Care Act? I don't feel that it's a good idea to give them an insurance card and yet there's no doctor they can take it to. So anyone on the panel that can address that, I would be appreciative.
Yeah, go ahead.
I was just going to say, one of the things that we have to do is train more primary care physicians. And in the early 2000s, there was a kind of mass exodus from family medicine, partly because, we do get paid the least, and we work the longest hours, and we have almost lowest risk, malpractice-wise. So there's actually been, I think, with some of these ideas of patient-centered medical home and the promise of maybe being paid for the quality of care you provide, we're having a return to primary care. Actually, this year for the match for family medicine residencies was, again, we matched more people than we ever have before. We've just partnered with UNC, we're in our second year of having 2 residents, actually eventually there'll be 6 residents at one of our rural sites, so we can attract doctors to North Carolina who want to stay in North Carolina and practice rural medicine. So I mean, it's in no way enough, but it's a start.
I think as we look forward to the baby boom generation requiring more care, more people having insurance, if we're not thinking that we're going to need, we aren't going to need more advanced practice practitioners, nurse practice PAs and nurse practitioners that are mid-levels that will be able to assist in this care. That's as far as we can see the only way that we're going to be able to provide care across the board. Because the number of physicians, the slots are not there. Nobody's willing to pay for residencies. In fact, residencies for UNC are going up because we're opening residencies in Charlotte and Asheville, but Carolinas is actually reducing their number of residencies, and it's anticipated that Wake Forest will also. Nobody's going to pay for medical education in these new systems. So we're really thinking that unless we start utilizing mid-levels and other providers in more efficient ways, people are not going to be able to get sufficient care.
I would agree that, again, this is something, that's what I was saying earlier about how we deliver care, is there are a number of the services, for instance, if you're obese and you need counseling, going to a physician who is frankly poorly trained in nutrition is not really the best way to do it. It's also one of the more expensive ways of doing it. So that's a piece of it. I do want to point out a policy issue there. While we have increased the number of medical school slots in this country, we have not increased the number of residencies. So what we're going to find, and this is true in family medicine, they have the highest match rate in family medicine this year that they've had. It's like 97%, which is frankly unheard of in family medicine historically. And finally, it's one of my colleagues at Blue Cross, who's no longer with us, but said, it's not the money, it's the money. We're working with primary care physicians right now. We have a quality-based incentive program called the Blue Quality Physician Program, where primary care physicians can have a significantly higher fee schedule if they hit certain criteria, quality criteria, experience criteria, patient-centered medical home criteria, so that we can help primary care docs be financially viable in what they're doing. We've also worked with North Carolina Academy of Family Practice to help fund mentors for medical students in their family medicine rotations, so that the experience of these medical students as they go out and experience family practice as it is far better. In fact, my daughter, who's in second year medical school, was just finishing her family medicine rotation. She said, it's like a gerbil on a wheel. 30 patients a day, and this is a guy who's a good practitioner. So we've got to really decompress. We've got to try to get a reasonable reimbursement there. We've got to worry about kids having a reasonable lifestyle when they go into this. So there are a number of pieces that we need to get into.
Okay, question here? Yeah.
I have two questions there, totally disparate. The first is, only one person has mentioned capitation that I've heard. I've heard bundled care here, and I've heard capitation there. And back in the 80s, we tried capitation, it failed. And I'm wondering, is there a way to make that model work, particularly in primary health care? So that's the first question. The other one is totally opposite of that, is we talk about these health link and this and that and the other. What are we doing to educate the lower socioeconomic people so that they know that there is somewhere to go besides the emergency room? Because if you've ever worked, I worked in low-income housing in Roxborough for a long time. Skip's smiling at me because I think he's from Roxborough when we were in high school.
I am.
Right. And we'll talk after today. Anyway, I was in low-income housing, and those people, they don't know. They are not educated enough to know where to go to get what. Oh, and they don't have an iPhone, they don't have a smartphone, and they don't have anything like we're talking about here. So what are we doing to educate them?
So let me make a comment about the smartphones. Actually, the penetration of smartphones is not dependent on income. We've done that research. You are more likely to see that in lower income, and it may be the only form of communication they have. They don't have a landline, so but let me go back to capitation. I was around, in fact, I ran from the provider side a large HMO population. I think the issues back in the 80s and 90s was that we didn't have the emphasis on paying for outcomes and quality. We were just lowering the cost, which, by the way, happened very effectively. It's one of the few times in recent memory that there were actually negative medical expense trends. But it was so objectionable to the patients. Not that they were necessarily getting bad care, but they just didn't like the idea of, I can only go here, I have to have a gatekeeper, blah, 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 blah. I think the Affordable Care Act, one of the pieces that is hopeful in this is the Accountable Care Organization, which is essentially figuring out how to coordinate care across and paying a single fee for it. It is, in a way, capitation. And we're still trying to figure out exactly how that's going to work.
I might also add, forgive me as an MC of jumping in here, but I worked on the West Coast and in healthcare for many, many years. And capitation is alive, well, thriving, and providing pretty darn reasonable cost effectiveness in many places west of here, particularly Southern California, where it has been in process for 30 plus years and works exceptionally well.
But Kaiser left here. They were here.
Kaiser's doing great in California.
I know.
They work here.
They were
Hold on just one second. It's 5:09 and I want to be respectful of everyone's time, so one question here and then maybe one more because you've been raising your hand, and then we'll wrap.
Mine is really simple because I'm a number cruncher and I have been trying desperately to understand what you all have been saying tonight, and it's really over my head. It's like talking to the dog. Cookie, treat. I just want your opinions about the cost. Are we actually addressing the cost in what we're doing and what is coming over the next few years?
So the Affordable Care Act was designed to do 4 key things. One was to increase access to health insurance. The second was to do some insurance reforms. The third was to improve the quality of care. And the fourth was to limit the rate of increase of cost. And I guess 1 of 4 is pretty good. The Act speaks to a number of pilots. ACOs are a part of that. There are a number of the Patient-Centered Outcomes Research Institute, the comparative effectiveness, but those are all kind of nibbling around the edges. Fundamentally, the healthcare reform is health insurance reform, which is needed, but it is not really addressing the cost of care, or for that matter, as much as the cost. It's really, one of the quotes I heard on this was, you know, healthcare reform is lowering the cost no more than Pell Grants lowered the cost of education.
Oh my God.
You know, it's really not as we're seeing it today. Now, that said, Medicare was passed in 1965. The Medicare that was passed then is not the Medicare you see today. This is a watershed event. Healthcare reform is a watershed event. It is the law of the land. It's needed. And we're just going to need to work with it over time to really make it better. And I see that's our role here.
We have one final question.
So starting in 2014, we are supposed to be able to buy insurance on the exchanges. And Dr. Bradley, you mentioned that Blue Cross Blue Shield will be offering a program on the exchange. Can you tell us, sort of at a summary level, how that will be different from the programs you offer now that are not on the exchange?
Did you say we're going to 10? So I'll try to be very brief. Programs on the health insurance exchange must offer essential health benefits. They must have a certain actuarial value, at least 60% actuarial value, and Skip can really speak to that better. As it turns out, in North Carolina, the essential health benefits will be modeled after the Blue Cross Blue Shield PPO because the state chose not to do a specific list of their own. It will be more expensive. The rating bands will be considerably compressed, so the difference between, you know, a very sick person and a young healthy person will be compressed considerably. The added benefits on preventive care, on taking out the things that we can't consider when we do health insurance rates like gender, health status, previous health conditions, all raise that median point fairly significantly.
I'll just add that this gentleman right here is the first person I've talked to that understands that when the exchange opens, that everything moves towards the middle in terms of rates. So out of a population, you're going to see winners and losers. 2/3 of that population will see significant change, either significant increase, then possibly some pretty decent reduction. And then this middle part will just see above average increase. So he won't give you the numbers on this, but I'll tell you that you should look for your young, healthy individuals to see their rates double. And as much as we would like to get those people in the system to help pay for everybody else, there's going to be less incentive for them to do that when you double their cost. Females and older folks may see a rate reduction. And if you qualify for a subsidy, then you may see costs become very manageable. And your question or your concern about people going to the exchange and buying coverage, that they'll be able to buy platinum, gold, silver, bronze. So it's not 4 options. They're just 4 different levels. There'll probably be 50 different plans from one insurance carrier. So if you have 2 insurance carriers, that might be 100 plans. Today, there are probably 3,000 different plans. So there will be a smaller number of options for people to select from. And
It's a range.
yes, it's a range.
Yeah.
I think the news.
With selectivity of it. You have to do your homework.
The news, I think, will be and this will be in the September, October timeframe when the rates start coming out. There are going to be so many people that are waiting for this marketplace to open, and I think they're going to be surprised at what they find there. That the lowest price plans, the bronze plan, that plan is a $3,500 deductible 50/50 HSA, which is not going to help a lot of your folks. They won't perceive that as being insurance because they can't afford the $3,000. The very, very low wage folks, but not quite Medicaid, they may also qualify for some, not only premium subsidy, but also some other subsidies to help make that plan better. And it'll be interesting to see. I am from Roxborough, and my great-grandfather helped open that hospital up there on Ridge Road.
It was just sold.
Who bought it?
LifePoint. They did everything they could to save it. My husband leading the financial services for the trustees. So y'all, that's what happens. We have no doctors and we have a for-profit hospital.
Just one other question. So if there's going to be insurers offering both plans on the exchange and off the exchange, will there be cross-shifting between those? Because it sounds like you have some restrictions on the exchange market that you may have to shift costs away from that to the other market in order to make it viable.
Yeah, so the prices on the exchange should be the same on and off. They kind of use the same risk pool, but not everybody's going to be in the exchange, as I mentioned earlier. So Blue Cross will be in the exchange, it'll also be off the exchange. And but if you're a carrier that is only off the exchange, then you have got a different marketing approach. You're trying to attract a different group of people to your plan.
The one other piece is that where it will be different is, remember President Obama said if you like your health insurance plan, you can keep it.
Turn it on, please.
It's on, I just haven't got it up on my console, so I guess. If you like your health insurance plan, you can keep it. That's called a grandfathered plan. Unfortunately, and I would tell you that the rates for that will likely be lower. So if you have a grandfathered plan, talk to Skip and figure out whether that's something you want to keep a hold of, because it's not subject to some of the rules that are in the exchange world. So that's just another, again, go look for it. I will cite one website that we've got. It's called nchealthreform.org, and it has essentially white papers on a lot of these issues, and we'll continue to update that as we go forward. And it gets into the detail about these questions. We could spend a month trying to explain this. This is why we have guys like to sort it out for us.
Okay, I think you would agree this was a very lively discussion, and I thank you all so much.